벌써 목요포럼은 15차입니다. 오늘은 또 헬스 에이징, 특히 이제 knowledge translation for health aging이라고 하는 굉장히 중요한 그런 주제로 연사를 모셨습니다. 연사는 일본의 그 가츠노리 콘도 교수님이십니다. 제가 간단하게 소개 말씀을 드리고 이어서 콘도 교수님께서 말씀을 주시겠습니다. It's a great honor to introduce Dr. Katsunori Kondo. He's a professor of social epidemiology and health policy at the Center for Preventive Medical Science, Chiba University, and the president of the Japan Agency for Gerontological Evaluation Study. He's also head of the Department of Gerontological Evaluation at the Center for Gerontology and Social Science, National Center for Geriatrics and Gerontology. He's the principal investigator of the Japan Gerontological Evaluation Study, one of the first prospective cohort studies to investigate the influence of social determinants of health and community social capital on health outcomes among older people. He has been selected as a technical advisor to the WHO and honored with the Medical Award 2020 of the Japan Medical Association. So it's my really pleasure to introduce Dr. Kono. Dr. Kono, now is your time.
Okay, can you hear me? Okay, can you hear me?
파일 좀 올려달라고 그러는데. Yes, we can hear you. It's
okay,
no problem.
okay. Thank you very much for inviting me today. It's my great honor and pleasure to be here and sharing our experience and knowledge with you. Now I will start. Wait a moment. Can you show my slide?
Yes, we can see your slide now.
Okay. Today's my topic in this lecture is knowledge translation for healthy aging. Lesson learned from JAGES or JAGES. This is acronym of Japan Gerontological Evaluation Study. This project is one of the effort translating the research findings to action or policy for healthy aging. We continued this project or initiative more than 20 years. So WHO, World Health Organization, found us, and they published one monograph concerning JAGES. So this is one of the good practice in research to action for healthy aging in the world. So today I will introduce what is JAGES, those overview, and also how to manage this research initiative, JAGES, and we summarize 7 key driving factors of JAGES. We hope this lecture is useful. The similar effort in Korea society. At first, this research initiative, JAGES, is focused on social epidemiology. You may know the social epidemiology. This is one branch of epidemiology focused on social determinants of health. And other characteristics of social epidemiology or social epidemiologist eager to contribute advocate and design a society less health disparities. I started this research project in 1999. Only 3 researchers discussed this research project, and we found 2 municipalities, relatively small municipalities. We asked them, please collaborate with us and conduct epidemiological survey with us. After that, we repeated the similar survey in which the participated municipality is gradually increased. For example, in 2003, 15 municipalities participated in this collaborated survey, and in 2010, more than 30 municipalities participated in, and in 2014 survey, more than 40 municipalities across Japan participated in this collaborated social survey. And researchers participated in this project also gradually increased, and now over 50 researchers from all over Japan participated in this project and wrote many papers using this data set. And this is a map. The municipality shows municipalities participated in this research project. And this is one of the few population-based gerontological survey in Japan, established in 1999. So we continued or repeated the survey more than 20 years. Our research interest is social determinants of health, so social epidemiological survey. In 2010, 13, 16, and 19, we repeated the survey, and more than 200,000 older people responded to our survey. A response rate around 70%. And this is the contents list of questionnaire of J-ages. The items relating to active aging and social determinants of health are used in this questionnaire. Health rating items include these: smoking, BMI, teeth or oral functions, and falls. And of course, alive or died is follow-up. In psychological factor, such as depression or self-related health are monitored, and concerning functions, activity of daily living are surveyed. Concerning social determinant health, we are collecting information on socioeconomic status, social participation, or social role, and social support. We also interested in not only individual factor, but environmental factor. So we measured community social capitals in several aspects. And this is one example of our findings from J-ages. We investigated the relationship between equivalent income, horizontal axis, and the prevalence of depression, vertical axis. we divided into 5-year age group. So you can see the same when you see the same color bars, you can find the relationship between equivalent income and prevalence depression within the same age group. As you can see in this slide, the equivalent income have a strong relationship between prevalence of the depression. For example, if you are rich people with equivalent income 4 million yen, the people who in poverty and the equivalent income is less than 100 million yen, shows roughly 5-fold higher prevalence. So it means that the socioeconomic factor, such as income, is a very strong determinant of health. And this is another example, the relationship between social network and the risk of dementia. We conducted a 9-year follow-up longitudinal study. The subjects was 14,000 older people, and we found that these connections to the society, such as have a spouse or support among family member and interacting with friends in the community and participated in community group activities, including sports club, hobby club, or senior club, and so on, or working. And the people having much more these social connections shows lower risk of developing dementia. So these kind of social connections or social participation is good for your brain. And this is another example. Recently, we published from WHO UPRO office, Western Pacific Regional Office. This is the prevalence of internet user by demographic factors. So older people is not use the internet, and poorer people, the older people with lower income shows lower prevalence of internet use, and the similar tendency observed for educational attainment, and population density is also shows such relationship. The older people living in rural area shows lower prevalence of internet use. So this is the famous internet divide or ICT divide. In other aspect, we found health protect effect. This is the blue bar shows not user in internet, and orange bar shows means internet user. And we conducted longitudinal analysis from 2016 to 19, and we used reference we used not user of internet for reference. So when we set the reference 1, the participant rate in 2019 among non-internet user, we found that, for example, 1.35 for volunteer participation and 1.69 for sports and 1.59 for hobby participation. So it means that the internet user shows higher incidence of social participation. So internet facilitate social participation 3 years. And this kind of social participation already known as a health protective factor. So internet facilitates social participation. Then all the people participated in this community organization keep their function. So and another analysis reported that the health outcomes are also better among internet users. For example, the incidence of depression is lower in internet user. The hazard risk is 0.66, and poor health-related health or incidence of hypertension or diabetes also lower, roughly 20 or 30% compared to not internet user. So internet user shows better health behavior in terms of social participation or meeting with friends, and also good health outcome in many health indicators. So I stop showing you our evidence. We summarized characteristics of JAZs. This is the list. We construct the large sample database, and many researchers want to use this big data. And the second characteristic is that multidimensional variables you can use. For example, bio, psycho, or social factors, including social health or social capital. Such variables included this data set. And also, JAZs has multi-level constructions. So you can use multi-level analysis. The individual data nested into school district, the number of school districts roughly 800. So you can analyze the contextual effect of community social capital after adjusting for individual social capital indicators. And the fourth characteristic is this is a cohort study or longitudinal study or repeated panel surveys. So, and we use municipalities' official record of public long-term care insurance. So the data quality is relatively high, and we can use several endpoints such as mortality and incidence of dementia or functional decline. And many municipalities participated in this research project, so we can conduct the evaluation study of several interventions conducted by different municipalities. And using these big data, we can publish more than 200 papers in English and more than 300 in Japanese. And we published or edited more than 20 books, and we are awarded more than 70 awarded. And we try to input the government or media's our findings. And this slide shows our findings. One line means one paper, and dotted line means cross-sectional study, and solid line means longitudinal study. And we found that many biological factors is one of the cause of healthy aging, or psychological factor, or sociological factor, and socioeconomic status, or life course factors, and community level factors, also the determinants of healthy aging. So based on these scientific evidence, we published several books and tell the society, Japanese society have a relatively huge health disparity, and we should reduce such health disparities in the future. And we also published the books in English. And most recently published book is Social Determinants of Health in Non-Communicable Disease from Springer. Following our scientific evidence, the Ministry of Health, Labor and Welfare Japan decided their health policy named Health Japan 21 revised. From 2000 to 2010, the term one, they focused on trials to prolong healthy longevity. But term two, 2030 to 23, second term, they add another target to reduce health inequality or health disparities. And they added the importance of improvement of quality of social environment, such as social participations. And this policy document cited our books or papers, so we contributed to the evidence-based policy making. And another aspect of JAG's initiative is community-based participatory research. We collaborate with municipalities and conduct intervention study of community building. This book published recently summarized the protocol for community building process. We collaborate more than 10 municipalities and made an effort community building in different municipality with different conditions. For example, very rural area to urban area, or mountainous area, or seaside area. This is one example of our community-based participatory research. We organized all the people as a volunteer, and make a plan and manage the programs. For example, physical exercise is very important for healthy aging and instructed by volunteers. And other cultural activity is some lectures or class for making a short poem. And this instructor also volunteer living in their community, such as a teacher in junior high school. This slide shows trend of number of participants and events. Blue bar shows the number of participants. And when we started the intervention in this town from 2007, and the number of participants gradually increased. And this is the results of process evaluation. Orange bar shows participants and blue bar shows non-participants. And the left-hand side shows males, right-hand side for females. And the vertical axis means rate of new participants, and even among non-participants, blue bar, 5 to 10% older people participated in newly in follow-up survey, participated in senior club, volunteer club, or sports club. Compared to that, the participants orange bar shows much higher, roughly 4 or 5-fold incidence observed in participants group shows higher incidence of participation rate in the community. So this kind of community intervention facilitate the social participation of older people into community. And we follow up the 5 years, and we compared between participants and non-participants in terms of the percent of persons function declined during 5 years. We found that participants, this number is opposite. The 300 participants shows around half of the functional decline rate. Not participants, around 2,000 people shows twice higher incidence of functional declines. So this intervention program is very effective, maintain functions, so healthy aging, it is effective for healthy aging. And I tell you, the internet use is very good for your health, and COVID-19 pandemic comes into Japan. So this kind of gathering program is, it is difficult to conduct this kind of interaction program under the pandemic. So we began the new community intervention trial using the internet. Meeting in SNS, such as Zoom, today we use, or Facebook. These SNS gradually spread even in older people. We conduct a survey, and the leader of older people's activities for about 50 groups. 7 groups, the leader of 7 groups already used this kind of SNS, and about 60% of group leader interested in this kind of ICT, information communication technologies. So we provide the opportunity to older people using tablet or SNS or smartphone as a new intervention study. So now we gathering or collecting the data, and now we are analyzing the database. Maybe in 2 years, we will make a presentation, the effect of this kind of intervention. Another aspect of JASIS is developing efforts of visualization system for healthy aging. This system named JASIS Heart, Health Equity Assessment and Response Tool. We collaborate with WHO Kobe Center, which try to develop urban heart health equity assessment and response tool. This is a management tool for all ages, but we have data for older people. So we developed JASIS Heart, a version of visualization system for older population and developed countries such as Japan or Korea. And we invited to the meeting on developing indicator for a global age-friendly state network. And we made a presentation, our experience developing age-friendly state indicators. This is one example of the JASIS Heart. You can easily find that which areas shows higher rate of participation into volunteering, or which area is needed to support by municipalities. And municipality civil servant easily find which area shows a higher participation rate, which means good practice in your community. So the municipality staff easily find out good practice in the municipality and find some crew developing such activity and disseminate such methods into other area of municipalities. Or this is another example of our visualization system. This scatter plot graph shows that the school district, one dot, with higher participant rate into sports group shows lower rate of falling down. So when we show these kind of results to older people easily understand participation into sports group is very important for prevention or healthy aging. So these kind of descriptive statistics is very important for community building process. After we developed this JASIS Heart, the government decided they also develop this kind of visualization system. This is one cabinet decision in 2013. They declare the government tried to develop this kind of visualization system for health and social care. And I am invited as a chair to the committee developing this information system. And we also contribute to municipality effort to developing healthy aging. One example is that the most municipality published public relations newspaper for civils. So we provide scientific materials each municipalities. This is one example published by Kobe City, and another example of Matsudo City, and this is another example for Funaba cities. And also we collaborate with NHK, public broadcast services in Japan, and one special program developed and broadcasted. And this special program tells the people, even in Japan, many people believed egalitarian society in the world, but the reality is different. Even in Japan, the significant health disparities or health inequality exists now. So the society should reduce these kind of unacceptable health disparities. So fortunately, we continued this research initiative, JJ's, more than 20 years. It is supported by many research fund agencies. For example, we get research fund from National Institute of Health, USA, or Japanese government, or you can find in right-hand side, we try to conducted the research, not only basic science, but also policy research or studies for practice. So we can get another research fund from AMED, Japan Agency for Medical Research and Development, or WHO, or other funding body. So I will summarize the key driving factors of JAGs. This is top page of monograph describing key driving factors published by WHO in 2018. And this scheme, this schema tells you the 7 driving factors. The first factors is win-win relationship between researcher, government, and others. For example, older people in the community, or NPO, non-profit organization in the communities. And the second factor is multi-sectoral action. So we collaborate with other sector, such as NPO or community or government. For example, Ministry of Health and the Ministry of Transportation and Infrastructure, or Ministry of Sports or other sectors. And third factor is that we build big data. So this data is very important. So knowledge creation using large-scale survey and researchers from multidisciplinary background build a team and write many papers. And the fourth factor is community-based participatory research, CBPR. The municipality sometimes cannot understand scientific paper published in English. So usual Japanese civil servant never read such scientific paper. So we try to we try to translate such scientific evidence into community actions. So we support municipalities to develop the community activities. And the fifth factor is providing management support tools to municipalities, Jesus had. So civil servant of municipality easily conduct community diagnosis and management their activities. And the sixth factor is advocacy via multiple channels. So municipality PR newspaper or public broadcast services or many medias. And seventh, the last but not least, and the strategic funding rising is very essential for research activities. We made much efforts to get many research fund from different funding bodies. All right. So this is a conclusion. Lessons toward research to actions. The first one is that the mindset of researchers are essentials. Some epidemiologists are interested in only finding risk factors, but risk factor epidemiology is not enough. The society want the solutions. So scientists try to seek the solutions for social challenges, and the perspective of social determinants of health, such as social capital, is very useful for such efforts. And second lesson is that big longitudinal data is very essential for scientific activities, and also evidence-based policy making for healthy aging. For example, the potential information communication technology under the pandemic of COVID-19, we can rapidly publish paper concerning this topic because we have already had the longitudinal data. So this longitudinal data is very useful. And the third lesson is incubator platform for win-win solution facilitate knowledge translations. We researchers have a meeting with local government staff or practitioner in the community every year. So such annual meeting provide us new research questions or opportunity to tell the people our research findings. Such a information, sharing information or research questions. Such opportunity is very important for us researchers and also civil servant or practitioner in the community. Thank you very much for attention.
Thank you very much, Professor Kondo. It is really our privilege to see your lifelong achievement for the elderly people and society. This is not just contribution to Japan. I think this is a really great contribution to the world, including Korea. So really thank you very much for your nice talk. It will be very much helpful for us to develop our strategy here. I have just a few questions to you. Because you show that education, particularly the internet use, that is very important, and there is a really clear the relationship between education, the attainment, and health outcomes. And you also said that it may not be enough to just study. So we need to seek some solutions to make a better society. So what is your idea or strategy to give in education, including internet education, to the older people?
Oh, thank you very much for your question. We also had the same challenges or same interest. So we conduct additional analysis, the relationship between the educational attainment and internet use and depression. Then we found that, wait a moment, maybe this slide have the results. Oh, you can see my slide?
Yes.
The black bar tells us the less educated people shows the 1.5 times higher prevalence of depression compared to well-educated older people. But we add the variables of internet use or not, the hazard ratio or decreased to 1.3. So it means that the more than 40% of reduction in odds of depression are observed. So even in less educated people, people who started to use internet decreased or reduced the risk of depression. So internet use is effective even for the older people with shorter educational attainment. So we decided we will support to start internet use of older people. So now we developed the educational program of internet use for older people. And now we are conducting intervention study right now.
Okay, thank you very much. I really hope to run how to make an internet education program to elderly people because that is a very much challenging issue. Because the older people, it's not easy to learn more about new technology. So another question, this is the last question. The US society, Japan society are much ahead in terms of aging. So I understand the more than 25% of all population is 65 years or older in Japan. In Korea, our number is 16%, so 10% gap. But we are catching up now in terms of the aging. So what is your advice, because you already experienced ahead more than, I guess, 10 years. So what is your advice to Korean society about the preparation of the Asian society?
Okay. For healthy aging, I believe that population strategy is more important than high-risk approach. In preventive medicine, many books wrote that there are two kinds of approach for prevention. One for high-risk approach, in which the high-risk people screened and invited to some exercise class or having some intervention. Contrary, in the second approach is population approach. In population approach, we don't use screening process. So any people comes here, and many people attend many activities. So such population approach is more important to healthy aging. In Japan, from 2006, high-risk approach for healthy aging introduced, and the Japanese government or society tried 9 years using high-risk approach to reduce high-risk people among older people, meaning older people frailty. But the result is that less than 1% of older people attend such class. So there are no effect in real world, but cost is very expensive. And some evidences from JAGs and other researchers, the government decided they changed the strategy from high-risk strategy to population strategy, or enlarge only high-risk focused approach to both high-risk and population strategies. After that, roughly 6% of older people participated in such community activities without screening process. And we found that roughly about half, 50% of participants is older people with frailty. It means that population approach without screening process shows higher participant rate of older people with frailty. So many people believe that high-risk strategy is more efficient because they screened high-risk people, but it is not real world. We found that population strategy is more effective and also efficient compared to high-risk approach, because much more, 3 times much older people with high risk participated in such activities. So I believe this is one good EBPM, evidence-based policy making. High-risk approach is not so efficient compared to a population approach. But population approach is has a problem or challenges. The impact or effectiveness of population approach is very difficult to understand or measured. So epidemiologist is needed to evaluate such a effect or a change in process of population strategies. So we epidemiologists or preventive medical doctors try to develop a good population approach and evaluate such a population approach and tell the results to the people. Those are very important.
Thank you very much. So your message is very important for our society, and your focus on the population approach rather than the high approach is very much relevant in our society as well. So yeah, this is a really good lecture and a good message, and thank you very much for your contribution. Someday I hope to see you in person about more discussion. So now it's your time's up. So thank you very much again. We are going to close this session.
Okay.
Thank you
Thank
again.
you very much.